Welcome to our Mary Greeley Primetime Alive presentation. It's Not Aging, Frailty, and Fall Prevention. I am Danielle Linder. I'm filling in for Vicki Newell today. As a reminder, if you'd like for more information about Primetime Alive or how to join, please visit our website, mgmc.org/PTA. Our presenter today is Dr. Michael Kitchell. Dr. Kitchell received his Bachelor of Science from Iowa State University, his medical degree from University of Iowa College of Medicine, and completed a neurology residency at the University of Iowa. He joined the neurology department at McFarland Clinic in 1979 and retired from there earlier this year. During this time, he was the board chair at McFarland, director of quality, and the chair of the Quality Council. Dr. Kitchell was the director of inpatient rehabilitation at Mary Greeley for 37 years. Dr. Kitchell was also the president of the Iowa Medical Society in 2009 and 2010, and the lead delegate from Iowa to the American Medical Association from 2018 to 2023. Please welcome Dr. Kitchell.
So I'm glad to see we've got a good turnout here today. The first thing I want to do, though, is ask a question, and the audience can raise their hands if they have fallen in the past year. Okay, well, I see a few hands raised. Mine is raised, too. I fell this summer as well, so we're going to take some questions and answer them at the end, but I'll try to get through this so there will be enough time for all the questions. There's a big cause for falling, especially in elderly people, and that's called frailty. Now, it's not just aging. You can age and still be a great dancer or a runner or even an athlete. But even though it is more common in the elderly, frailty means it's a condition of being weak and delicate. That is, being a little fragile. The main problem that leads to frailty, though, is inactivity. This summer, I actually ruptured my Achilles tendon, and so I was inactive for a while, and I found myself, as I was recovering, having trouble with my balance, too. So inactivity leads to more frailty. Now, there's a group of us in Story County that is called the Story County Fall Prevention Coalition. It's a group of about 20 to 22 healthcare professionals, and we are trying to educate the public and get them aware of the assistance that you can get to try to prevent frailty and falls. So how frequent are Americans falling? Every 20 minutes, an older adult dies from a fall, and every 13 seconds, an older adult is treated in the emergency department for a fall-related injury. During the last year, about 3 million Americans were treated in the emergency department for fall injuries. About 29% of people age 65 and older actually fell during the last year, and actually half of those people had more than one fall. About 37% needed treatment or at least a period of decreased activity because of that fall. And I think this is pretty obvious. Bad things happen when you fall, and about 800,000 admissions occurred last year because of injuries from falling. Head injuries and hip fractures are the most common injuries, and 20% of the elderly who actually had a hip fracture died within a year. So it's not a good sign to have something like that happen. About 33,000 deaths occur from falling per year, and 66 out of 100,000 falls will result in death. And then if you are on an anticoagulant, that means if you're on a blood thinner because of atrial fibrillation or blood clots, that anticoagulant puts you at a much higher risk of having serious injuries. And I think we all know that the cost of healthcare is going up, and it doesn't seem to have any decrease in the future in sight. But the main thing I want to emphasize here today is we can reduce the cost of care by reducing the incidence of falling. So every time you don't fall, you're saving Medicare and the insurance for everyone some money. 6% of all Medicare payments are for fall-related injuries, and 8% of Medicaid payments are for fall injuries, including the nursing home costs. So just the total cost of a hip fracture for a fall is about $51,000. It's a little cheaper in Iowa than it is nationally, but still $50,000 in cost for a hip fracture is pretty amazing. It takes about 5 to 6 days in the hospital to have the surgery done, and then after the surgery, the patient goes to a rehab or a skilled care facility, and that takes usually a couple of weeks, sometimes 3 weeks to recover. So it's about a month that a hip fracture patient has to be away from home. And actually 25% of the elderly spend at least a year or more in nursing homes after a hip fracture. Those are the really frail patients. So not only are there hip fractures and head injuries, ankle, leg, and pelvic fractures also can lead to hospitalization and rehab. And then the arm fractures and wrist fractures can also lead to some hospital stays. Patients who have osteoporosis or osteopenia, they are at higher risk, obviously, for fractures. So as it was saying, prevention is a lot better than treatment, and the cost to an individual who falls is great, but the cost to the taxpayers or the people who pay the insurance is also great. Now, the hospital, I've been on the Quality Council here at Mary Greeley for a number of years, and one of the measures we've had for at least 10 or 12 years has been the number of falls by patients who are in the hospital. And that's one of the main goals of the Quality Council, is to reduce the number of falls, especially any falls with injury. So Medicare actually has quality measures, which include fall risk assessments. If you go to the McFarland Clinic, your doctor will ask you if you had a fall in the past year, or if you are afraid of falling. And so those questions are part of a quality analysis or a quality measure. And as I said, Mary Greeley has a number of quality measures that they track. And part of that is falls with injury. So you know it's a challenge when people are in the hospital, they're confused, they have to get to the bathroom, the nurses are down the hall. The risk of falling then for a patient who's a little confused or not feeling well or is dizzy, there's a risk of falling. So Mary Greeley has a number of measures, a number of interventions to try to prevent falls. So as I said, these quality measures are tracked to try to avoid injuries to people or some other harms. And that is going to avoid some costly care in addition to what they were in the hospital for originally. So as I was saying, those inpatient falls are difficult to prevent, and the strategies that are used include some bed alarms or a chair alarm. If you get up out of bed, the beeper will sound, and that's the same with any movement out of the chair if you are being monitored for that. So the staff come running if those alarms sound. So there are conditions that increase the risk of falls, and just like I said, frailty is one of the main concerns. And it's not just aging, it's the condition of being weak and delicate. And I'm going to talk a little bit more about gait disorders, like a horse's gait. Your walking is a little uncoordinated or a little wobbly. And one of those diseases that causes a gait disturbance is Parkinson's disease. So I'm going to talk about that, as I said. One common problem, though, that people don't realize can cause a higher risk of falling is medication. And I'll talk a little bit more about that, too. One thing that is often missed is sometimes when people are on a blood pressure medicine, sometimes when they first get up, their blood pressure actually drops too low. And so they may get weak or wobbly or faint, and they will fall. So I'll talk a little bit more about dizziness too, which obviously is a risk for falling. Now, as we all get older, 85 years is about the time that approximately half of the population needs a cane or a walker. And as a neurologist, I took care of a lot of people who had a history of balance difficulty or dizziness. And our exam, as a neurologic exam, would include watching the person walk, see if they could do what's called the tandem gait, that is one foot in front of the other. Romberg is watching them stand and keep their eyes closed to see if they can keep their balance when their eyes are closed. We also check patients for a blood pressure drop when they stand. It's called orthostatic blood pressure. And then we check their sensation, because some people, for example, a diabetic patient who has a diabetic neuropathy, that is nerve damage from diabetes, sometimes they are numb in the feet and legs and they lose their balance because they don't have the sensation of which way they're leaning or going. A lack of vitamin B12 is also associated with some balance difficulty, so that's something that a neurologist would check. And then if the diagnosis, including a brain scan, is all negative, a neurologist may say you have a gait disorder. And like I say, sometimes that's Parkinson's disease, or sometimes if we don't find a cause, it's just simply called a gait disorder, because some people, as they get older, either from some small strokes or from just deterioration in that part of the brain, they do have balance difficulty. Now, Parkinson's disease, I'd like to have people raise their hands if they know somebody close to them, either a friend or a relative who has Parkinson's disease. Yeah, see, that's over half the audience here. And as a neurologist, I took care of hundreds, probably thousands of people with Parkinson's. And everybody with Parkinson's disease is a little different, but not everyone with Parkinson's disease has a tremor. But the typical features of Parkinson's disease is that they're a little slow. That is, their gait is slow, they're a little unstable. They sometimes shuffle a little bit. They have trouble getting up out of a chair. They have trouble getting started, that is, initiating their gait. They also have a loss of associated movement. That is, they don't swing their arms very much. They tend to just stay rigid, and their arm swing is reduced. They sometimes lean forward, and they have a very stiff type of posture. When we check them, they have a slowness of their alternating motion rate testing. Their trunk is rigid, and their extremities are slow or stiff or rigid as well. They can have a masked face. That is, if you look at them and you see how much they blink, you'll notice that their face seems like a mask, and they don't blink very often. They can have a low voice or a hoarse voice. They can have a mumbling type of speech, and they sometimes drool or have a little trouble with their swallowing. So the patients with Parkinson's disease luckily can be treated. There are some patients with the Parkinsonian syndrome who don't have Parkinson's disease, but they have features very like Parkinson's disease, and those I can just mention a little bit about those later. The most important cause of falling, though, like I say, is frailty, and age is a risk factor, and it's often avoidable if you are motivated to stay active and exercise. And then a lot of people, including myself, get arthritis as we get older, and the joint problems, whether it's hip or knee arthritis, that limits their activity, and so that decreased activity will then lead to frailty. So we want people, even those with some arthritis conditions, we want them to stay active, and we'll talk about that later too. As I said, though, gait and balance difficulties are not really due to arthritis. They are due to a condition that is a medical condition. Now, as I said earlier, medication is sometimes a problem, and if you're taking a sleeping medication, that's a real danger. That increases your risk of falling by 9 times. You're 9 times more likely to fall. And then people who are on some antipsychotic drugs for their mental illness, they also have an increased risk from those drugs for their mental illness by about 9-fold. Muscle relaxers for your backache or your neck ache, and sedatives like an antihistamine to clear up your stuffy nose, those can also make people more likely to fall. And as I said, mental illness, some antidepressants are worse than others. They increase the risk of falling as well. And as I mentioned, sometimes the blood pressure, when it's too low, can cause people to be dizzy, lightheaded, and faint. And so a blood pressure check is also important for people who are having trouble to check their blood pressure when standing and compare it to sitting blood pressure. And then, unfortunately, some people are on opioids. Those pain relievers are dangerous. They can cause confusion as well as balance difficulty. And benzodiazepines like Valium, those are medications which are very likely to cause more balance trouble too. They checked the patients and the hip fracture patients who were in the hospital because of their hip fracture were on more than 10 different medications prior to their falling. Now, I'm not going to spend too much time here, but I do just want to talk about what a neurologist is evaluating, and that is a neurologic condition. So one of the more frequent Parkinsonian syndromes that as a neurologist I see is called progressive supranuclear palsy. I've probably seen about 100, 150 over the years. And these are folks that have trouble with their balance, and they typically fall down the stairs because they have eye movement problems and can't really look down very easily. So they're walking down the stairs and have bad balance, they'll fall. So that's a Parkinsonian syndrome. Another Parkinsonian syndrome is called multiple system atrophy, or the Scheidegger syndrome. And those people have those features of Parkinson's. As I said, they're slow, and they're rigid, and they have trouble getting up, they have trouble getting around. But they also have a problem with their blood pressure, so that whenever they get up, even not on medication, their blood pressure drops, and they can't really be upright for very long unless they have a medicine to raise their blood pressure. And so that's a real problem with this multiple system atrophy. There are other neurologic conditions that are rare called corticobasal degeneration, and those are people that look very Parkinsonian, but they have more tone problems on one side or the other. That is, they're more rigid on one side or the other. And then the strokes are not as common as they were when I first started out in neurology, but there are still many patients who have small strokes that don't get recognized until they have a brain scan, and they are found to have some small vessel deterioration or small vessel strokes, not a major stroke, but multiple small strokes. There are other conditions called cerebellar degeneration. And as I mentioned, polyneuropathy, a diabetic patient, for example, who has nerve damage in the legs could have a real problem keeping their balance and avoiding falls. The more rare conditions that we see that are actually treatable, there's a condition called normal pressure hydrocephalus where patients have balance trouble, gait difficulties, they have some memory trouble, and then they also are incontinent. So if you have a combination of balance difficulty, dementia, and incontinence, neurologists should be evaluating that patient. And then I sometimes see people who have spinal cord problems, either spinal stenosis, where the bones of the spine actually pinch the spinal cord in the neck or in the upper back, and those patients have trouble keeping their balance because of that spinal cord trouble. And then I've had a personal experience with subdural hematomas. This is a condition which is some bleeding under the skull, pushing on the brain, and it's usually due to trauma. I had a bike accident 2 years ago, and I recovered from that. But 6 weeks later, I was taking aspirin because of another condition, and I found myself staggering around the hospital. And I immediately went to my partner, Dr. Moore, and I said, I need a CAT scan because I think I've got a subdural hematoma. And sure enough, I had bilateral subdural hematomas. So this is a condition that's treatable, thank goodness. They drilled burr holes into my skull and drained the blood. And so 3 days later, I was home. It took me a while to completely recover, but so subdural hematomas are something that is sometimes missed, because I was 6 weeks after my bike accident and I was back at work. I was actually seeing a total of 12 patients that day that I got my subdural hematoma diagnosed. So these are conditions, though, that need to be evaluated by a neurologist. And so hopefully, if it's that serious, your doctor will refer you. Okay, so let's talk about dizziness, because there are a lot of causes of dizziness that don't lead to falls. But sometimes dizziness is a vague symptom. And so a neurologist would ask, is it intermittent? Is it triggered by position changes? For example, if you're rolling over in bed and you suddenly get dizzy, that's what we call benign positional vertigo. But is it a condition of being lightheaded? Well, that could be either anxiety, because a lot of people have anxiety attacks and they feel unsteady or unnerved. And then sometimes it's due to medication. As I said, there were a lot of medications on that list that we need to avoid. But we occasionally in neurology would see people who would say, I feel dizzy, meaning I don't feel right. I don't feel like I'm on balance. And so those patients may need a little bit more workup for their condition. The exam, like I say, includes evaluation of their walking and whether they can walk 1 foot in front of the other. The Romberg test, watching their balance when they close their eyes, and then checking their orthostatic blood pressure, seeing whether the blood pressure drops. Now, as I said, it's pretty easy to kind of find a medication or a combination of medications that are a culprit in people who are having trouble with their balance too. So I'll mention that again. So it's pretty clear that if you've had one fall, you're at risk of having another one. And if you have multiple falls, you're definitely at a higher risk of falling. And as I was saying, avoidance of falling is much better than the treatment after a fall. So I do want to just talk about some of the ways that we can help to prevent frailty and hopefully prevent falling. And as I said, frailty is not an inevitable problem of aging. Both Prime Time here at Mary Greeley and the City of Ames have some exercise programs. And I'm going to invite Dr. Greg Welk from Iowa State to come up here and talk more about the Walk with Ease program. Greg is part of the Story County Fall Prevention Coalition. And so I've given many talks with Greg telling the audience exactly what they can do to evaluate their risk of falling, as well as have a better exercise experience. So, Greg.
So I'll get behind the microphone here. Thanks, Mike. Yeah, I appreciate the chance to share a little bit more. So I'm a professor in the Department of Kinesiology and have a strong passion for fall prevention and older adult programming. So we have been leading a program called Walk with Ease for 5 or 6 years now, and it's available in multiple places around the community. It's a free 6-week group exercise program. It's available in the community center in partnership with Ames Park and Rec, but also at the Ames Fitness Center, in the Forker building on campus. We're opening up new programs at Story City in Nevada, and so there's a lot of options to sign up. The program's available for any older adult, 60 and older, but we also offer a specific version for fall prevention. So in that case, you have to be 65 and older and have a risk of fall. So as part of that, we do free fall risk assessments to identify if you might qualify for the trial. So there's handouts at the top of the stairs, or when you leave, you can grab one. And I think Danielle might be sending out the notes or the flyers as well, but you can also email us at walkwithese@IA State, and our team will get back to you about if you're interested just in a fall risk screen. We'll do a comprehensive screen with surveys and functional tests, and that's on one of the flyers. And then again, there's another flyer on Walk with Ease if you're interested in either or both. So I'll leave it at that, Mike. But yeah, happy to answer any questions at the end or pick up a flyer. Thanks.
Yeah, so we'll stick around for questions. I'm just about done with my presentation here, so Greg can come down and answer some other questions too. How many of you have gone to the 60 Forward Center here in Ames? Great, great. I think that's wonderful. I hope we can all meet there occasionally. The NIH, the National Institute of Health, has a website also too if you want to do even more research. I've been getting physical therapy this summer since I ruptured my Achilles tendon, and believe me, weekly physical therapy has really helped me to improve. And physical therapists are experts at teaching patients how to do things differently and hopefully reduce the risk of falling. Exercises are helpful, but just the awareness of what to do and what to do differently is important. So as I said, the most important thing for prevention of falls is staying in good health, that is exercising and being physically active. And then it's important to review your medications. If you're in doubt, make sure your primary care doctor reviews them for you and answers your questions as you see your primary care provider. And then vision is important. Obviously in the dark, if you don't have a night light, you probably should get one. And make sure your vision is good enough so that you don't have trouble navigating places. Safe environment is very important. There are too many people that have clutter and they put throw rugs where they shouldn't be. I know of a lot of people put up Christmas lights or clean out the gutters, and ladder safety is very important. When I was the director of rehab, I saw many people who fell off a ladder or fell off a height because they didn't be aware of their balance. You need grab bars and handrails in the bathroom and the shower. You need non-slip mats. You need good lighting. You need good footwear. And if you have it on icy or slippery surface, you need to make sure that's treated. And as I was saying, the more severe the gait or the balance difficulty, the more people need the physical therapists. So as Greg has said, The fall risk assessment is important if you're not really sure how good your balance is. There are some fancy, expensive tests too, called functional balance tests, though, that don't have much value besides the basic gait evaluations that a neurologist or your primary care doctor could do. Early intervention, like I say, that is using exercise as a preventive way to do this. And then those multifactorial interventions have shown definite benefits in preventing those falls. So as I said, physical therapy should be given to anybody with a very high risk. And then there's gait and balance and functional training, resistance training, flexibility, and endurance training. Depends upon what you need. And then there are some other exercises that are good. Tai Chi, yoga, and various dance therapies. As I said, the Heartland and 60 Forward, as well as the City of Ames, have obviously many opportunities for exercise. Vitamin D and calcium in high dosages is not helpful, but if you're low on vitamin D and your calcium intake is low, you should add some vitamin D and calcium to your diet. An excessive amount, though, is not that helpful. Okay, so the summary today is the simplest screening test as we see people in the office at McFarland Clinic is to ask, and it's usually the nurse that will ask, have you fallen or are you fearful of falling? Because those two questions are important. And as I said, frailty increases the risk of falling with injury, and then medication and checking your blood pressure when standing is very important. And the more the patient has a gait disorder, the more they will need to see a neurologist to get an evaluation of that. So frailty is not just aging. Frailty is being weak and delicate. So let's all not be so weak and delicate here. So Danielle, I think there are probably some questions online, and there may be some from the audience here too. So Danielle is going to bring the microphone to anybody in the audience. So raise your hand if you have a question, and Tim can give us any questions from the chat line.
Get my steps in today.
My name is Renata Delman, and the question may sound a little silly, but when you have age groups with risks and benefits, after 75, we who are older than that seem to be falling off a cliff. So I'm 90, and so you might want to say something about the really old.
Yeah, I'm over 75 too, so I'm in that intermediate group. But people who are 90 and who don't need a cane or a walker are exceptional. But I would say the same advice, though, for any age over 60. Please do some aerobic exercises. And Greg can talk a little bit more about the Walk with Ease program, if that's something you'd like to do. But is there any other question that I can answer? I'm definitely preaching to anybody over 65 today. So.
Then was to you, I have done Walking with Ease, and it ended, of course. But is this also an ongoing program? Can you just re-enroll and keep doing it?
Yeah, we did have to shut down during COVID, but we are back up and running. We start new cohorts every semester, so yeah, you can re-enroll. Probably it depends on how the structure works, if you were enrolled in the trial or not. We probably can only have you test once, but you can re-enroll in the program.
I'm just going to have you repeat that, okay? The question was, is Walking with Ease an ongoing program?
Yeah, the Walk with Ease program is ongoing, so we enroll new cohorts of participants every semester. So we will be re-enrolling for the January timeframe, so right off the New Year's resolution timeframe to get off to a good start. So yeah, there's time to re-enroll or to continue walking. The other thing we do with these partnerships with Ames Park and Rec and the Ames Fitness Center is enable walking indoors. Like until our new fitness center is built, there's kind of a shortage of indoor walking spaces in Ames and Story County. So you can walk at the Ames Rec Center and you can walk at the Ames Fitness Center through, I think you might have to pay $2 a session or something, but they are very open to partnerships to support more walking programs for all of us. So.
Great.
My question is, how many steps per day? It used to be 10,000, now they've lowered it, and I keep reading that because I keep wanting to get my steps in. And I think I kind of like that when they said 3,000 a day, but what do you think the average is to stay in good health?
Go down with Dr. Kitchell there. There we go.
This is good.
And would you repeat the question?
Sure, I'll comment about that step question. I get that question a lot. So how many steps are enough? And 10,000 is kind of a mythical number. It's a nice round number, but it's not the standard. So the goal would be to do a few thousand more steps than your normal routine would be. So to go out for a 30-minute walk every day would increase your number, but you don't have to hit 10,000 to call it an active day. So the general rule of thumb is it's about 2,000 steps per mile. So if you're walking 2 or 30 minutes, you might accumulate about 1 to 2 miles. And so that would be 3,000 to 4,000 extra steps over what you normally do. So one way to do it is to just determine what your baseline steps are on a day when you're not active, and then try to bump that up by about 3,000 or 4,000 steps every day.
I inherited a stationary bike from my husband. And the winter is coming and ice and snow will be out there. How beneficial is a stationary bike? Is it the duration of sitting on it, or how high you set it, or what is the best way to use it?
Yeah, I'm a big advocate for biking as well. So my best answer to what's the best form of exercise is it's the one you'll do. So if biking's available and easy and safe, it's a great exercise. It's probably not going to provide the same benefits for fall prevention because you're not learning to balance. But any aerobic activity is going to reduce frailty and improve your fitness and strength. So any activity is good.
Did I misunderstand? You said you could, about the Walk with Ease program. I was in it one time, my husband was in it one time, and then I was in it this next time. I took physical therapy before I was in the Walk with Ease because I didn't think I could do it the first time, which it was great. But did you say you can qualify to be in it again? Because what I understood was I couldn't, but if I belonged to the Ames Fitness Center, I could continue to walk with them, but they wanted you to be a member, of course, to participate. Did I misunderstand what you just said?
Sure. No, it might depend on whether you're enrolled in our clinical trial. So the clinical trials have a little bit of different rules about how we can't enroll the same person because then you would count twice. But you can re-enroll in the non-trial version of Walk with Ease. Or the other thing we're trying to cultivate is just ongoing walking. So it is a short program, 6 weeks. So we'd love to build in kind of a continuity where you can keep walking with others or find peer groups of walkers. So we're working on that. So email our team and we'll work with you. If we have a lot of interest, we'll form walking groups that are for graduates of Walk with Ease that you can keep walking because now you know the exercises, you know the routine, and it just creates a structure. So that's probably where we'd land on that, is more of a walk with Ease, extension, if you will.
Well, I have her here. I do have a question about, you said the vitamin B12 deficiency is commonly associated with balance trouble. I'm just wondering if you could elaborate on that. Why is that?
Yeah. Vitamin B12 is an essential vitamin that sometimes is missed because if somebody is taking some other vitamins like folic acid, they may not be aware that their vitamin B12 is low. So a physician would need to check the vitamin B12 if they have some balance difficulties. And people with vitamin B12 deficiency have what's called subacute combined degeneration. It's a spinal cord problem. And so they get a little numbness sometimes with that. And they have a proprioceptive problem. That is, they don't know which way they're leaning or moving. The Romberg test is abnormal in vitamin B12 deficiency. And I'd say probably 1 out of 100 people in the elderly age group has vitamin B12 deficiency. It's not due to a lack of taking vitamin B12. They have a condition that involves not absorbing vitamin B12. So if you have some balance difficulty, if you have some numbness in the feet, your primary care doctor can check a vitamin B12 level very easily. Now, one of the things that Dr. Welk talked about is there are studies, and this is what's so good about having Iowa State nearby. Dr. Welk has done this Walk with Ease and has published studies that show that this is an intervention which helps to prevent falls. There's another researcher at Iowa State who researches some therapy for Parkinson's patients, and she is an internationally renowned researcher on treatment for Parkinson's patients. So again, we're just lucky that we have Iowa State here, and those studies can be published and they can help other people besides those in the community.
While I'm walking to our next question, Tim, do we have any questions online?
Yes, we just had one come in. Can you take too much vitamin B12?
No, you can't take too much vitamin B12, but it's useless if you're taking more than what you need, and you can easily check the level on a blood test.
I hate to talk again, but you might want to talk about the PAS study, the long-term study that's going on at the university. It's a fabulous program.
Yeah. That's another study that our Department of Kinesiology runs, so I'm not as involved in that one. It's what's nice about the PAS study, Physical Activity and Aging Study, is it's an ongoing cohort study. So you get like a free evaluation every year, and you kind of know where you're at with a lot of functional tests, but then we study the changes that happen and how your lifestyle influences your successful aging. And so that's another example of research, but we need your help, but it's also a benefit to all the participants. So glad you reminded me about PAS. Of course, yeah. So that it's an ongoing cohort study. So again, you can sign up and get your evaluation, and then you keep coming back every year. Do you have a phone number or anything for them? I don't, but you can email, either you can just reach out to the Department of Kinesiology, or if you email our Iowa State, my email, walkwiththese@Iowa State, or gwelk@Iowa State, I can get you to the right people.
The kinesiology department at Iowa State is actually a very popular major for the Iowa State students. So there's a lot of work being done at the kinesiology department.
We do have one more question here.
Mike, you didn't touch on this, but would you also explain what is the difference in leading Parkinson's patients onto Lewy body dementia?
Yeah. People with Parkinson's disease, unfortunately, about 1/3 of the people who have Parkinson's disease will eventually develop a dementia. And that dementia is called Lewy body disease, Lewy, Lewy body disease. Occasionally, a neurologist will see a Lewy body disease patient with the dementia before they have the Parkinsonian features. So there is a variation. I'd call it gray versus black and white. Parkinson's disease, as I said, is not the same in every patient, but about a third of the people with Parkinson's do develop a dementia called Lewy body disease. You probably have heard about chronic traumatic encephalopathy. And that is the football players who develop a dementia. They also develop a Parkinsonian syndrome, not Parkinson's disease. You remember Muhammad Ali was a great boxer and he had Parkinson's disease. Surprisingly, he did not have chronic traumatic encephalopathy. He had Parkinson's disease. So Michael J. Fox is the most prominent person who's had Parkinson's disease for over 30 years. So not everybody with Parkinson's disease will develop a dementia, but unfortunately about a third of the Parkinson's patients do have Lewy body dementia.
Thank you both for what you do. On the vitamin D, what is the recommended level, and is it true that if you're heavier, you don't absorb it as well?
I'm not an expert on vitamin D, but it's easy to check a vitamin D level. And the dosage would be the minimum daily requirement. But if you're low, talk to your primary care physician and they will give you some vitamin D supplements. And if you have osteoporosis, you should definitely be on vitamin D. So,
Any more questions?
as I was saying to you, an excess of vitamin D is not helpful. So don't take too much vitamin D.
Would that be vitamin D3 or D in general, or?
D in general.
Okay, the other question I had then was, I've heard of a symptom called POTS, positional orthostatic something.
Yeah, orthostatic tachycardia syndrome.
Okay, and I've known two people that seem to have that. One is like early 50s. The other is more my age, like in the 70s. So I'm just wondering about that.
Yeah, that means when they stand, their heart rate speeds up and they may feel faint. It's not necessarily the same as an orthostatic blood pressure drop, but it's basically the same type of woozy, lightheaded feeling. And POTS can be in younger people too. But the problem is a lot of people who are inactive, if they are laid up for a while because of a fracture or whatever condition that they had, if they don't get up and walk every day and exercise, their blood pressure control is not as good. So they can have a temporary POTS type of syndrome too. So. Okay, I think that's probably all the questions then, right?
Thank you for joining us today, Dr. Kitchell.
All right, thanks. Thanks, Dr. Welker.
I just have some final words here. Thank you so much for your time in preparing for this presentation and for bringing your colleague to talk about Walk with Ease today. Upcoming programs for us are Diabetes and Prevention. It's never too late. It's on Thursday, November 14th at 2 o'clock at the 60 Forward Center. We also have a presentation on lung cancer, earlier detection, and new minimally invasive procedures, Wednesday, November 20th at 2 p.m. at the 60 Forward Center. And not on this list, but I do know is coming up as our holiday gathering. So I hope you can all join us for that. And thank you for joining us today.